Hello, my name is Dr. Ben Marble. I am here with our YouTube channel. As always, if you like what you see, please hit like and subscribe. We had a question come in. We have quite a few patients that have diabetes, and as a result, they suffer from something called neuropathy and also many times peripheral arterial disease. So that means poor circulation, poor feeling in the feet. And so many times when I see them, sometimes for the first time, we have to deal with something called an ulceration. It's a wound, essentially. It's on the foot. It's occurred because the patient hasn't been able to tell, for whatever reason, that there was maybe a rock or a dime or something in their shoe. I've even had patients that have come in after walking and they've stepped on like roofing nails, and that roofing nail's been on their foot the whole day. They have an infection, they have a wound, they're already compromised as far as their healing potential as it is. So what they want to know is, what does a typical visit look like when I come in, if I'm seeing you for the first time? So first of all, what we do is many times we have to take x-rays. They come into the office. We've done a comprehensive history and physical with the patient. The patient's foot, their medications, how their blood sugars are doing, how are their vitals. We take all that into account to see whether we need to just send them emergently over to a emergency room right out the gate. And so if they are having any systemic signs like fevers, chills, nausea, vomiting, or just general malaise, or the blahs is what we call that, then we just pull the trigger and get them over to the hospital as soon as possible, because they likely are going to need IV antibiotics and maybe even something more comprehensive as far as surgical care than what we can provide here. But if it's not out of control, if there's no redness, swelling, drainage, or pain that's out of control as well in the foot, then what we do is we go through that process of the intake. And then once they come into the office, I've had a chance to ask them any questions. We take a multifaceted approach. Number one, I evaluate their blood flow and their feeling, and see where we're at with that. If we need to do any kind of testing, like circulation testing, we do that all here at Pueblo Ankle and Foot Care. We also assess the feeling in their feet. If we need to address the neuropathy, many times it's been a long time that they've been dealing with neuropathy, so there's not a ton of stuff that we can do other than protect their foot from ongoing damage. Then, once we've identified those things and we've also looked at the x-rays, made sure there's nothing additional inside the foot, like a foreign body, that I may need to remove, then we go through the process of culturing the wound if it's actively infected. We can use a swab and send that back to pathology, and what pathology will do is they'll identify whether there's a specific bacteria that needs to be addressed, and we will give them an antibiotic before they leave, with the idea that might change if they end up if that pathology report comes back different than what we are prescribing at that time. The antibiotic that we need to give them is different than what we've prescribed. Then what we do is I assess the wound itself, and so we need to measure it before I start working on that wound. Once we have pre-debridement measurements, and the word debridement, that means removal of dead stuff, dead tissue, just necrotic, bad stuff that doesn't belong in the wound. And incidentally, the thing that's the most important with wounds is not what we put on it, not the jams or jellies that are out there like antibiotics or Neosporin or Mupirocin or any of those types of things, the topicals. It's what we take off of the wound, and that includes not just the debridement or removal of dead stuff, but also it means removing pressure. Many times a lot of these wounds are on the bottom of the feet, and so as podiatrists we're skilled at making sure we're doing something called offloading, which is removing the pressure from that area so that the patient's foot can heal. And so once we've done the measurements of the wound, now we're ready to actually debride the wound. And so what that involves is different instruments like a soft tissue nipper or a curette. All these things can help to remove dead tissue from the wound. We even have a surgical blade. This is a disposable actual scalpel that we use to remove any callus or any dead tissue away from the wound. Once we have done all of that and the wound bed looks beefy red, that's what we're looking for, is a nice beefy red base of the wound. Then we're ready to then talk about what we're going to be putting on the wound, including possibly 2x2s, which is a type of gauze, 4x4s, which is a larger gauze. On that wound would be like the things that we typically utilize are Medi-Honey, iodosorb, betadine, which is an iodosorb is a betadine-based paste, it looks like baby poop essentially that we're putting on the wound, but it helps to absorb drainage and even blood flow, and it impregnates an antibiotic into the wound. We also have Hydroferra Blue, which is another topical that we apply into the wound. It has a foamy type of texture to it, and also antibiotic impregnated. These types of things, again, are not as important as making sure we keep pressure off the wound or removing dead tissue regularly from the wound. And so after we've verified as well that the dressing is in place, then we take, first of all, we have to take the post-debridement measurements as well to see how the wound looks after we've removed it, what size there is, so we can have those measurements for the next time that we see the patient, see if it's gotten worse or if it's gotten better. But then after we've done that address the wound, then we make sure that we do a proper offloading with either a surgical shoe that has special offloading in it, involving felt that we've moved in the position on that surgical shoe to take pressure away from that certain area. There's even a product called Peg Assist that has small removable squares that you can take out of the bottom, and it would diffuse pressure, and I'll show you what one of those looks like in a future video. But then the patient ends up going back home, and that's when really the rubber meets the road, right? It's because I can do everything here in this office, but if they don't follow the instructions that I've given them, then the patient's going to have a hard time healing. And so it's a challenge for us to be able to, number one, communicate really well what they need to do, but number two, make sure that everything is appropriate for that wound. There's many different aspects to the wound that could end up changing even over the course of days. And so we also advise them if there's any increasing redness, swelling, drainage, pain, to come or to call our office. And we usually are in contact with them anyway within several days to a week, to hopefully sooner, more like 2 to 3 days, to be able to get the results of that culture that we took back to them and change the antibiotic if we need to. So as you can see, there's lots of things that go into doing wound care. I hope this was helpful as far as understanding what happens with a typical visit here in my office.